So I just want to make sure you're all aware of our new protocol that we're rolling out. It's going to be eventually in all 4 of our hospitals on how to replace drugs for the non-transported patient. Some of you might have had the opportunity to try it already. So patients not transported, whether it's a code, diabetic, whatever, or asthma, you have to bring in the patient care report. You fill out that report, the form that's next to the Pyxis, what you need, hand it to a nurse. The nurse will add the patient's date of birth, hold the medication, hand it to you. You'll not have to go down to the pharmacy. You'll be able to get your stuff right away. But the key is we have to have a patient care report in order to do that. The second patient care report goes into the mailbox in the EMS room. So this will decrease your delays. The only problems we've ever had so far is like when the shift before says they gave glucose, but they never had a patient care report to give you. That happens, we will have to send it down to pharmacy. It can take up to 6 hours. It'll be just like an exchange for an expired drug. So it's easier for you to just bring in a patient care report. So it's in our hospital now. We are rolling it out to all 4. I know at Glenbrook, the EMS coordinator just got back from vacation, and at Evanston, they just are putting up the policy. So it'll be just a little bit, and it'll be everywhere. So today we're going to go through cardiac, and it is a very brief review. It's our last class for the year, so we won't be going too much. Obviously, the circulatory system, if you think about it, it's a pretty important thing going on here. The heart's pumping the oxygenated blood, and then it puts back the deoxygenated blood through the ventilation, through the pulmonary system, and pumps out. It also takes around your water, your sugars, your hormones, your neuroreceptors. Everything is going through this way. So it maintains your temperature. It also keeps you from going to shock. It just takes cellular hyperfusion to cause shock and possibly death. Quick review of the heart. Obviously, the blue is where the unoxygenated blood is coming in, either from the superior or inferior vena cava. It goes into the right atrium. Right atrium is like a kind of a more lax side of the heart, let's call it. Just lets it fill. And as it fills, it actually just trigger and opens up the valve by kind of more gravity force. Goes down to right ventricle. Eventually, now we have to use some force or some muscle contractibility to go up through the lungs, come back down, oxygenate, and go back out through the body. So this part, what do you think the normal SA node is? It's the normal trigger in our electrical conduction system. What is the heart rate? 60, 100. What if it is lower in the AV node? So now it's almost in the ventricles. Yeah, 40 to 60 is common, but on something rich in there, you might see 40 to 55. Okay, so if you go even further down to the bundle of his or bundle branches, it actually drops down to a heart rate of 25 to 40 usually. Okay, so the ST segments, and actually looking at a normal rhythm here, this is where the sinus node kicks off, tells it to give this little PR interval. But the most important thing is if you see the J point here, is when you're looking for ST elevation, don't read that when it's wide, starting down here with the ST elevation starting from way down at the S point. That'll give you a false reading. This actually, if you look this J point up, would have to go up to almost here for it to be considered a STEMI. It is only 1 square in the ventricle leads, and it could be up to 2 squares in the limb leads. But now they're finding that if you're seeing, we talked about contiguous leads, and if it tells you what part of the heart is damaged, if you see one area with an ST elevation, no, it's not diagnosed as an ST or STEMI, but it's usually a really good warning that something is going on. It's kind of like a yellow light saying something is happening. So there's 3 factors about cardiac output. So the preload is actually, again, the right side, it's filling up the atriums. It's actually more, it's a way of filling by volume. Afterload is actually when it's kind of being pushed out. And contractibility is actually the strength. Heart rate can be dependent on how much work, what's going on, if there's a fever, if there's injury. So the heart rate is affected by different things, different transmitters, and actually can decrease the amount of carbon dioxide is pushed out if it's too fast. What you care about, it's a very big deal about keeping this in the normal volume. Too fast, too slow, if the contractibility or the work of the heart is not strong enough, you're not going to get great cardiac output. So this one I want to spend a second on. we show this every year, and everybody's like, why do you keep on showing this every single year? And it's because we're still looking to improve our quality of our 12 leads. So V1 and V2, no one really gets this wrong. We're all really good at counting down to the fourth intercostal space. We got that. V4, everybody goes to the mid-X. We go to our line, we put it in there, and then we fill in the blanks with the 3 and the 5. V6 is probably the one that is most commonly kind of off-center, let's say, because we don't go down and follow it all the way through to under the axillary, so you kind of go straight down. And I just wanted to point out the V4 over here. So if there was an inferior wall, you would take the V4 lead here, move it over on the exact opposite side. When you look at the 12 lead, the only thing you're going to look at is the right V4 and make sure you mark that 12 lead. So depending on how fast you can tell me these rhythms and your answers, it'll tell you how long we're going to have to take to go through these. So there's a 54-year-old that called for a stub toe, and you did a rhythm, and this is what you're seeing. What do you see? Pardon me? Normal sinus. And are we going to do anything with this? Maybe an ice packer's toe. Okay, so this is a person who's 48 years old. She's dizzy. She's hypotensive. What is our basic rhythm here? Brady. And is it a block? Is it junctional? What is it? What do you think? Sinus probably, because the P wave's up, right? Would you say? Close to first degree, but it's up and it's regular. And is there a treatment for us? Can you treat sinus Brady? Huh? Atropine, how much? 0.5 and fast. She was symptomatic. She's dizzy. This one was dizzy. Oh, well, we're not on that one, are we? We're on this one. Okay, so atropine 0.5, very rapid, or it has an opposite effect. And then you can consider pacing. If any of you had to pace somebody recently, if any of you pace somebody who's awake, you really do need to consider sedation and pain meds. And what is your rate when you pace? 80. And what is the normal amount it takes you of energy to get capture? The lowest you can get, but what is normal? Do you know what you normally see? You see about 30s. You always want to go a little past, quote, capture so that you don't lose it. So 80, and you do it till capture. Atropine, they are giving a picture. It can come 0.5 to 1 milligram. It can be going IV, IO, ET. We never really give it ET anymore. I've never seen it. Hopefully you never have to because you can put IO in. Which block does not get atropine? Third. Very lovely. Oh, and here we have a rhythm. She's 68. She's unresponsive. She has a pulse. What is our rhythm? It's very clean looking P waves. I mean, very clear. So are there more P's than QRSs?
2, 1. Yeah, but it's...
Okay, this is type 2. So, look, what do you think? So, there are more P's. Are the PR intervals constant when it's before the QRS? No. Is it always following the short, longer drop if you think it's a second degree type 1? No. This is a third degree heart block. The R to R's would march out, the P to P will march out. So when you look at it really quick, because look at that one, that's short, and that's really long. Now that's less long, that's short again, there's one drop, so there's kind of an irregularity. But it is not a typical, but they're calling this a third degree heart block. So blocks, first degree, PR interval, there's no extra P's, PR interval is longer. Second degree, there's PR intervals. It's a very irregular looking rhythm. The PR interval lengthens until eventually there is no conduction, no QRS. Secondary type 2 can look regular, can look irregular. Definitely more P's than QRSs, but when the P is in front of that QRS, the PR interval is constant. Third degree, definitely more P's than QRSs. They do not have any relation. R to R's usually march out, P to P's usually march out. There is no constant there. So we have a 28-year-old who has this rhythm, SVT. So now, would confusion be considered a symptom? Yeah, altered mental status. So what is the treatment for somebody with just this little bit of information, 28 years old, you could consider, if you felt she was really unstable, you could consider shocking. So I would probably try to see what else we could do, but depending on how unstable she was. So this guide here I want to share with you is incorrect for the monitors you are carrying, because the model of Zoll here is the M series. It's the old series of Zoll. You actually have a newer series. So if you had an SBT was stable, you're going to do adenosine. You're going to follow it with a flush, 6 milligrams. You're going to follow it by 12. And you can also check to see if they are AFib, because it can slow. If they are an AFib or there's no response, I wouldn't be giving Verapamil if they weren't AFib, but you can give Verapamil very slow. They say over 2 minutes, and it's at least 2 minutes. But I want to say here that it says synchronized cardioversion at 100 joules or equivalent biphasic. Does anybody know what your equivalent biphasic is on your Zoll series? For synchronized cardioversion. Okay, and that's what I thought it was, because that is what is on ours, but I found out that on your new one, it is 70 or 75, depending on what yours is set for. So it is 75, goes right to the 120 to 200. And actually, Ken's going to be sending out, or Gabe's going to be sending something out to show you that that is the new range. Okay? Adenosine is a very short-acting drug. I mean, it only lasts 6 seconds in your whole system. It actually can cause conversion for SVT, and it works generally only on the stable monomorphic VTAC. So what is this rhythm? AFib. If this was rapid, would you think you would try? If it was rapid and they were stable? Okay. Okay, I guess that's true. If it's rapid and they were stable, though, you could start considering cardamom. I mean, nausea, vomiting. So what is this one on the bottom? AFib. So Valsalva, Verapamil, if it's AFib, if they're stable, very slow, hopefully never have to repeat it, and synchronize again, it's 100 or your equivalent. Now, AFib does not convert easy. AFib in a hospital, if we have the luxury, like there's somebody who's got this rapid AFib for a while, they're stable enough, but the only way we can get them out, we try medication, doesn't work, is actually we conscious sedate them, and we will use high amounts of cardioversion. I understand that your Zoll leads don't go front and back. Is that true? Yours goes front to side? Front to side. Ours is we sandwich. So it depends on the series and the direction of where it tells you to place the leads. Again, that's very important to tell you how the energy is going to work. To your design, we will do the front and side on synchronizing AFib, because it really is the only way we can convert them. We will move it for our synchronize. Verapamil, well, you know I don't like this for peds because it's very dangerous. It is a good drug if it's used correctly. It's a calcium channel blocker, so by blocking certain channels where the drug exchange goes, we can sometimes drop the rate, and hopefully if you do it right, you can do it safely. What is this rhythm? VTAC, would you say a 60-year-old with shortness of breath and VTAC is stable? No. Okay. She's breathing. She is breathing. So what is our treatment? What's our treatment? Stable VTAC. What's the first treatment? Adenosine. Most people don't get that, by the way. So you try one try of adenosine, because a wide complex tachyrhythm, 80% plus the time is VTAC, but sometimes they think it could be some other rhythm. So you give it a one-time try if they're stable, and you give them adenosine. Otherwise, you can go to amiodarone in a drip. It's 150 and 100 over 10 minutes. Polymorphic, which is the one before, which is the tersize, is coming for multiple sides. Actually, you do amiodarone right away. If it's not monomorphic, you don't try adenosine. If they're unconscious again, you're synchronizing. And here it says synchronize cardioversion at 100
joules. I don't know why it doesn't say or equivalent. Actually, when they're rewriting it, it should say or equivalent by phasic. However, to be honest, we will never start synchronized cardioversion on somebody in VTAC under 100.
Can you fill those two rhythms back up?
Yes.
Side by side? So you're saying,
So when it doesn't it's not even, I mean, this is really hard. It looks like somebody can be, it's probably starting from a different sensor in the ventricles, okay? So it's starting from a different site. This one is, while it's a VTAC and it's pretty dangerous, it's actually starting from kind of the same location in the heart. This one, the heart is like kicking it off from all over the place, and most likely this one will turn into a VFib much easier. It's a lot more dangerous rhythm when it's coming from multiple sites. When it's, okay, so unstable, here it says 100 joules. You could try the amiodarone. As long as you have a pulse, you're always going to do it as a drip, and you can keep going up. Something you should know in coming up in Tersatis, in the new changes, they are actually even talking, and some regions are already doing it. We are not synchronizing people with pulses. We are actually defibrillating. So that might be a change you're going to see.
What happened?
It's just not converting. So they have a better chance of converting it with the defibrillation versus the synchronized. It's not here yet, so I'm just telling you that's something that is changing. Amiodarone, like I said, this was made for SVT, but that market was taken, so they decided to take out the arrhythmia market, and they're doing 150 and 100 over 10 minutes. You really just want to make sure you don't run it wide open. You can stop if you get results. What is this rhythm? AFib. Okay, you guys know this treatment better than anyone. What is your treatment for AFib? Electricity. So what do you think your first energy is for defib on your Zoll monitor? What do you think? What's your first shock at? 120, 150, 200. You never go over 200. You'll fry the heart. On a Zoll monitor, it is made not to go higher. You will have the same effect out of 200 on your Zoll monitor as on another monitor at 360. You'll be giving too much energy, and actually yours should be locked out. It shouldn't be able to go higher. After CPR for 2 minutes, you would shock again. So if you shocked at 120, what's your second shock? 150, then you can start your EPIs and your amiodarone. The 30-2 ratio is a basic ratio. It's a basic healthcare responder or public's ratio, 30-2. Advanced healthcare providers should be considering non-stop CPR compressions and interspacing back respirations. They don't want you to come off the chest at all. If you cannot get the airway managed, of course, then you can stop for up to 10 seconds, but they really found that it's not as effective for the patient if you stop at all. So continuous compressions is considered advanced CPR. Okay, so the ratio here, they're giving you what the basic guidelines are, but if you take the list, the new class, you'll find out that for the advanced, it is trying to keep the compressions going at all times and trying to get the breaths in. So here we are. This is basically what we just told you about. So transitioning from somebody with an AED, let it finish the cycle, and then what does it say? Perform it in shockable defibrillation. Go defibrillate at your max joules. So if somebody was on an AED, or if somebody has an automatic internal defibrillator, you would want to start at 200 because it was not effective. The AED is set to a fact that it's going to go at a different number of joules depending on the AED model, but they don't have that, it can transition up. They're doing it at their highest rate. So if they're doing it at the highest, you have to go one step higher. If it's not working, you would then go to the max of yours, which would be 2 for the adult. Can anybody tell me the most common 2 H's? Okay, very good. Thank you. So we want to give fluid volume. Want to give them good oxygen. We want to make sure their potassium's not low or high. You can tell that by looking at your leads. Your rhythm. If they're cold, you notice here it doesn't have hypoglycemic. It is one of the H's, and that is because that is part of your basic assessment. And if somebody is hypoglycemic in a code, they will not come back. So it's something that you have to start considering because it is part of your basic assessment when you get a cardiac arrest to get that blood sugar, because they will not convert if their blood sugar is low. You do not blindly give blood sugar. You don't blindly give glucose, but you have to check the blood sugar in a code. Okay. So if you have the fib, we talked about it, you can give epi after 2 shocks. You can then go to amiodarone, you go to 300 because there's no pulse, and you keep on going, and the 360 or your equivalent would be 200 for you. Epi comes in 1 to 10. Is anybody else having trouble getting epi 1 to 10 out of the Pyxis? Somebody said yesterday they couldn't get it out. And they signed, huh?
It's grayed out.
Why? Well, I called and reported it, so hopefully they'll get that fixed. They said they can get epi to 1 to 1,000, but they couldn't get epi to 1 to
350 was the same. EMS volume is grayed out.
I didn't know about that one. I'll call Mary Grace. Okay. So epi 1 to 10,000 is what you're going to be giving in code every 3 minutes. And remember, if you don't bring a patient in, bring in the run sheet and bring in the sheet. We'll be able to exchange it. 1 to 1,000 is generally used for allergic reaction, or anaphylactic shock. There's some other reasons we'll give it. What is this rhythm? They have no pulse or asystole, right? And it depends. You're allowed to treat this as spine fib if you identify it as spine fib, but if you identify it as systole, you should be only treating it, not shocking, checking a different lead, and actually, I would call this asystole. The only medication we're going to be giving is epi, and we need to give fluid challenge because we're going with our odds. Hypovolemia is number 1 cause. Hypoxia is the number 2 cause, so we want to make sure we ventilate them good, we do good CPR, we give them fluids. We're going with the odds, and we're getting them epi. Return to spontaneous circulation. This talks about the hypothermia treatment. This is going to be pulled off as soon as the new SOPs are coming out. We are going to still have you do an assessment on the patient. Obviously, we want to make sure you're going to treat them appropriately, but we are not going to start the hypothermia therapy in the field. That is definitely a pull-off. Withdrawing resuscitative effort is different than calling to confirm a 000. Call a 000. You saw somebody with advanced signs of death. You was telling me you got no pulse, you got no blood pressure, you see pooling, you see rigor mortis, whatever you see, last seen so long ago. If you do a code, you start the code and you want to stop, it is a physician in the ER that has to get the permission to withhold efforts. We are never going to pronounce this patient. We are going to simply say that we are withholding further efforts or withholding efforts at a certain time, just like when you call with the 000, we won't give you a time of death. There is no time of death. It's time that efforts have stopped, efforts have ceased. So you're not going to be able to see, there's no time of death unless you have a coroner sitting there with you. They can do it. What do you think this rhythm is? It's not the most typical one I've seen. What do you think? Actually, it's a pacing rhythm, and it's not, usually now we have dual pacers, so you actually see a larger spike that goes up and down. I'm not sure where this is inserted, because you're seeing just a small spike, and you're actually seeing looks like an inverted, looks like kind of a wide PVC almost, but this is a pacer rhythm. We talked about this. So once we know that it's not firing, you're no danger, you're going to defib at 360 joules or equivalent, which is 2. Ken is calling the manufacturer of your new Zoll to see if they differ on this point. But I can tell you at the hospital, anytime there is an automatic internal defibrillator or somebody's on AED, we do go to the highest joules. Acute coronary syndrome, this buildup starts at age 14 or so, and actually with some diets even less. As you can see, as it starts building up, you got to think about the increased pressure. This is where you're going to start seeing the blockages. Depending on where you're seeing a blockage or ST elevation or depression will give you an idea of where the damage is in what part of the heart. And actually depression could be old damage or it can be showing a reflection, kind of a mirror damage of where an MI is occurring. What rhythm would you say, what would you read this 12 lead as, I should say? Would you want to have this 12 lead on you? I would. This is a normal. There's no ST elevation. It's nice and regular. I don't know how, they're 48, that's okay. I'll take their 40. Good age. This one, not as good. Where's the elevation? 2, 3 ABS. So what's our treatment?
Right side of 12 leads.
Right side of 12 leads. So if this person had a good blood pressure, let's say probably hypertension, they're like 200 over 100, let's say, and they are awake and they have severe pain, and you do the right before. Over here, you don't see any elevation. That's the only one you're looking at. You would ask medical control, do you want me to go ahead and give the aspirin and the nitro? Because we want to open it up if it's a left inferior. Sometimes they're just afraid that we're not able to see it, because now going to from a limb lead to a cardiac lead, so it's a smaller raise, you'll see a smaller elevation. So they might hold it, but we really want to open it up as soon as possible if we're allowed, especially if they have a high blood pressure. Otherwise, if they're low blood pressure and it's right inferior ulcerative fluid. Did I say that wrong? I don't think I said it backwards. Okay, so you can give aspirin, nitro, you give morphine unless it's an inferior wall, or you get permission. Aspirin is something that it's really helpful. It does not break down clots. However, it does prevent further clots. And what happens when there's an MI, it's an assault to the heart, your body is trying to go to that thing, and actually when they see this clot forming, it's trying to break it down, which is sending more sensors, more proteins there, which is building up the clot. It's increasing the clot. By putting the aspirin in early, we're helping further damage not happen. You can't break it down, but you can prevent further damage sometimes just by giving aspirin. Nitro has a different effect. It's actually there to try to open up any vessels, try to push past that clot, try to get as much oxygen and blood flow to the area that is being damaged. An aneurysm is a little different. This is a person actually can have it depending on where it happens. If you have an aneurysm that's over, I think it's about 5 centimeters, actually that probably will start to rupture. They rupture, it's a life threat. Sometimes you can't repair it depending on where it is and how quickly they can get to surgery. Dopamine is being pulled off of certain regions. It is being added to protocols in our region. They are now going to be asking for more dopamine drips started in our septic shocks in the field. They found that these people will respond better and have a better outcome and actually live, because if they go into septic shock and we don't get their pressure back up, they have a very poor outcome. So we are going to be adding dopamine to septic shock, and it's going to be much more aggressive, and we are going to still be using it for our hypotensive. The 5 mics is really no good in the field, but that's where they tell you to start, and you don't want to cause hypertension with it. We just want to get it up to usually about 90. LVADs, one group told me you had an LVAD in town. The other 2 groups didn't know anything about the LVAD in town, so I don't know if that's true or not, but I do know that Evanston is putting in LVADs in patients. There are multiple different categories of LVADs or different types of machinery that's being used. This is very similar to the one that we're going to be using. It's a lot easier for those who had that patient a few years ago. I think we had 2 patients in Skokie, but the one that was a 21-year-old guy that was his birthday party, and he was down on the ground, and he was unresponsive, and the person with him didn't know how to use his LVAD. It's over a holiday. The person at the hospital wasn't answering to help guide us, and the equipment was very, very big and bulky. So the new equipment is much easier to read. It gives you better displays, digital displays on what you need to do. It gives you better warnings of how much battery time you have. Make sure you only, if you had to change a battery, you only change one at a time. That is not changed. You will look at the patient. If the patient is not responsive, and obviously you probably won't feel a pulse. There are sometimes you can feel some pulses on patients or get a blood pressure, especially if a Doppler, but you don't have that in the field. They say here, do not place the paddles or right over the device. It'll totally kill the person. But you can actually put it next to the device, and you can actually defibrillate them, and you can actually do CPR if the person is unresponsive, basically looks like crack. Person unresponsive and their color is pink, most likely they're not in a cardiac arrest. They're unresponsive for some other unknown reason, and you should follow your altered mental status. The patient in cardiac arrest is not going to look nice and pink and have a good color. It's very hard because their rhythms, we had the guy in the air that looked like Trosadas, and he's sitting talking to us. And we were looking at, we have no pulses, we have no blood pressure, and he's talking to us. So obviously he's talking to us. I'm not going to be shocking the guy. but sometimes they don't give you that wonderful clue. This you're going to be seeing, and have you seen anybody with this, by the way? We discharge patients almost daily with this on now from all of our hospitals in the area if they're using this. This is called the Life Vest, and these people need to have an internal defibrillator put in until they can get scheduled, until the cardiologist can schedule a procedure, and I do believe it's partially for insurances to discharge people to safely lead their life. They wear these Life Vests, which is kind of like an automatic internal defibrillator on the outside. It will give a loud warning, and it does this warning whenever they see the person's going into a rhythm, like a BFib, and basically it's for the person, our trained, that they hear this loud warning, stop your car, sit down. It doesn't have a voice prompt, it's just like an alarm, and then it will shock a few seconds later. So in case the person is going into some type of arrhythmia, they will shock them. You'll treat it the same way you treat an internal defibrillator. It's not a high amount of energy going in, but it's still something you should be aware of. Capnography. We do have the capnography available for you to have replacement for either nasal capnography or for the ET. We have both of them in the paramedic room. Normal level is 35 to 45. So the difference is O2 sat actually just kind of shows saturation in the patient's blood. The actual end-tidal CO2 is actually how well they can ventilate. The mechanical process, are they able to push the byproduct fraction out, the carbon dioxide out. There's multiple devices. It is actually a good way of verifying the ET tube, but cannot be the only way because it will give you a good reading if you're in the right main strength. It won't tell you that you got it correctly, so you still have to listen to the lung sounds on both sides. It's going to tell you if you're doing good quality CPR. It can tell you also different things if you're having somebody's asthma, somebody's a COPD, or it's going to look a little different. So a normal has a nice kind of flat top. You'll see the inspiration is obviously a little shorter. The expiration's long, but it gives you enough range that it can let you deliver a rate of 35 to 45 pressure. Sudden loss waveform. This is where we think about the dope. All of a sudden the ET tube is dislodged. You're going to see it suddenly drop. If the person has had a nice range flow, all of a sudden the color drops, changes. Check to see if the tube came out or if there's a leak or if something happened. CPR should maintain at least 10. Sudden increase, that's where you're seeing the spontaneous circulation come back. Now this shark fins, that's for asthma, COPD, and also could be somebody who is having either partial choking. You ever heard somebody who's like choking, but you don't do the Heimlich because they're still making sounds. They're still talking. They're kind of doing like wheeze, they're very audible wheeze, and they're the ones that like to leave the room because their eyes are teary. And you can hear the sound. They actually go into a bronchial spasm, and if you had hooked them up, you would see these really shark fin things. We also see that in asthmatic. Hypoventilation, actually they're not ventilating enough. That's why you're seeing such a prolonged thing. And hyper is not any better. You're not going to be able to get a good exchange. I think we talked about that. So here is another way of checking. You want to make sure you check after the tube. You check the tube and then you check for the placement, and you should see this if you're doing CPR at least at 10. Things that can affect it is pain, shivering, hypothermia, anything can change it. So if you're breathing too fast, too quick, it will change that. And that is all I have on this. Let me turn off the